I'd just like to thank the organisers this morning for giving me the honour really to chair this next session. I'm Monica Lappenpohl, I'm a Professor of Integrated Child Health, Community Child Health here at UCL, and I'm really here to learn from all of you and listen to the experience of all the speakers here today. Even though most of my work is based in the UK, I'm really learning from the low-income countries. When I go out to do my clinics, we have major problems with access, people who can't speak English, we may have mobile phones, but behavioural change, all the things you're talking about, scaling up, and we have those problems here in the UK, and in some cases probably more so, and not achieving as much as what you are out in the resource-poor countries. So I'm very excited about the day today. The next session, I'll just explain to you how the next session will run. We've got an eminent speaker, Dr. Mehl, who will be talking for about 15 minutes, followed by 15 minutes of questions. That will be followed by 3 different speakers, running one after the other, and then we'll have about half an hour for questions for all the speakers, and you can give us your questions to everybody who will be sitting up here on the panel like the previous session. So a very exciting morning. Followed by that, you'll all be pleased to know there will be lunch. People with the blue stickers, I think it is, have been asked to go outside, and the lunch will be on the landing after we finish this morning's session. And for other people, there are lots and lots of places around here where you can find places to eat, and there are seats downstairs near the cafe downstairs as well. It's a lot of time to mingle and chat with each other and share experiences. So I don't want you to hold you up from your lunch, so we'll get going. Dr. Mehl will be up here in a second as a gentleman who I'm in awe of, really, for the many things that he has done. We've been talking about scaling up, and he has led some of the projects that are involved with scaling up. He's a leader in evidence synthesis at the WHO. He's a principal investigator in the mHealth research study. He's a principal scientist as well for the Thrive study, so many, many different things he has led. He's also worked at the Rockefeller Foundation, the World Bank, Johns Hopkins University, and the International Eye Foundation, and I'm sure had other partnerships elsewhere as well. So without any further delay, I introduce to you Dr. Garrett Mehl. Thank you.
This is really quite a pleasure to be here, and especially in front of so many interested people in mHealth and evidence, and especially as it relates to low and middle-income countries. Just want to try see here. So I want to take you on a little bit of a journey that relates to the WHO's role with a number of partners on understanding, looking, reviewing, and developing frameworks and methods to synthesize the evidence base. And we're midway through that journey, or part of the way through that journey, and we hope to bring on other participants into that journey with us as we begin to get to a point of being able to recommend mHealth strategies to governments and implementers around the world. I want to, again, this is sort of an overview, and I want to talk a little bit about the role of evidence, the mechanisms of synthesis, some of the language that's been developed, and some of you may have come across that, ensuring that consistency of language, and then looking at mHealth primarily for the LMIC audience as a health system strengthening tool, and then looking at it in this post-2015 era of universal health coverage. So governments face many choices around the world, and those choices are really constrained by finances and really risk intolerance. So they need to ensure that the investments that they're making are evidence-based, and they're going to be ones that maximize health impact at minimum risk. And so they like innovations, but they like others to be implementing them and assessing the evidence of them before they get to a point of adopting them. So a lot of the pilots we hear about are really to reflect the need to develop that evidence and ensure that those tools are functional and have the effect that is expected. WHO, as many of you already know, supports the generation of evidence and distills that evidence into guidelines and best practice tools, makes recommendations to governments. So it's meant as a neutral broker. It also helps formulate national plans and actions with governments, so the governments can be confident in the investments that they make. Some of the guidance that many of you would have seen relates to national strategies and actual program management tools as well. And it's presented characteristically of WHO in a fairly dry way, without a lot of advocacy, primarily because it's really, the evidence is meant to speak for itself and presented in a fairly neutral way. There have been a lot of calls over the course of the last 5 or 7 years or so on the need for increased evidence, and we've heard a lot of that discussion this morning, and that evidence needs to be applied to ensure that those who are investing in mHealth are doing it wisely. A lot of scale-up has taken place, but maybe even in the absence of evidence. And then Tomlinson's article reflects this concern that was faced, and really looking at, well, if we're scaling things, let's make sure that it's evidence-based at least, or informed. In 2012, an article by Labrique and others suggested, in fact, that there were a number of trials underway, and that that evidence base was being collected, and at some point very soon it will be in a point where that synthesis can take place. I think it was a hopeful sign, but it's an emergent field, and the majority of articles have been published in the last 3 or 4 years, and that speaks to the fact that mHealth is not monolithic. It reflects a real diversity of uses of mobile technology, wireless technology, and that the field itself is filled with innovators who are testing and trying different ways of using mobile technology. In 2011, we recognized that there was a need to begin to develop the approaches that would be relevant for synthesizing and reviewing evidence, and made a call for increased evidence to ensure that the technologies are being understood and are being promoted accordingly. The mHealth Working Group, which is out of the United States and is primarily made up of USAID partners, but reflected a growing population of users, and there was already some evidence synthesis that was being done by these groups, and reflective of a real need for synthesis. And the high impact practices documents reflected both on family planning and then also the work that Carolyn Free, who's in the audience, had done on really looking at a systematic review and looking at the state of the evidence at the time, and really contributing to the fact that there was a growing evidence base, and there was the potential, and there is the potential of beginning to make recommendations in this area. And this is a document, or a paper that reflects on the use of communication strategies for children's health. And the recommendations are that I've circled here are recommendations based on the strength of expert opinion, as well as the strength of the evidence base itself. And it's a 1A, and you can see that a number of recommendations are being made here. And so this is reflective of an evidence synthesis approach, and then a body of experts reviewing that evidence base. This doesn't happen to be a WHO one, but it does reflect that there is a need to make recommendations and make sure that we're confident in those recommendations. In 2012, we initiated the mHealth Technical and Evidence Review Group for mHealth for RMNCH, and the aim of which was to provide governments and implementing agencies objective, evidence-based guidance for the selection and scale-up of mHealth strategies across RMNCH, which is the part of WHO that I'm based in. Part of that role was to define and catalog what types of mHealth we were talking about, ensure that we have the criteria for evaluation established, to then go through the process of understanding the evidence gaps and beginning to develop recommendations where there is insufficient evidence, but also begin to synthesize that and make recommendations for to governments for which strategies should be implemented, institutionalized, and scaled. And begin to look at appropriate mechanisms. So we've heard a lot about a lot of pilots. Well, those pilots are very much to establish the efficacy, but moving to effectiveness in real-world settings, and then institutionalization by governments, who are then partners to ensuring that it's integrated and it's supported in the long term as a sustainable part of their national plan. The MTurg sought out to develop a standardized language to describe mHealth, classification taxonomy, criteria for describing implementation and evidence grading methods, and standard indicators on mHealth maturity. These are fairly geeky parts of mHealth synthesis, but important. And I just want to kind of go through a little bit of the thinking behind it and some of the products. So broadly, there are a number of interventions, health interventions, that have already been validated. Among those, vaccinations, vitamin A, and other interventions that I think all of you are aware of. And those are typically synthesized in a series of documents called essential interventions that governments are recommended to introduce. The challenge is getting the coverage and the quality of those interventions up to a sufficient standard. And there are weaknesses of that delivery, of that intervention. And whether that's poor demand for services, or failure to follow guidelines, or their stockouts, or the insufficient workforce, et cetera. Those are all constraints and challenges. And mHealth, the way that we have looked at it within the MTurg is that mHealth provides those bridges to overcome those challenges, those constraints. And those are strategies themselves. So we can break that out into the technology, which really comes down to the software, the code, and the functions. And that's usually encapsulated into an app or a platform that you might have come across, like RapidPro, for example, or TextIt. And mHealth strategy is the actual use of that for a particular purpose to overcome those challenges. And, for example, text messages to improved information demand for ANC visits. And a project, of course, is the use of the strategy in a particular locality, using a particular technology, and typically that's branded in some way, like Ananya, BBC. And the health intervention itself is the ANC visits, or the vaccines, or the vitamin A. And that's a specific intervention. We know that it's targeted to a particular audience, and there's a schedule related to that, and it's important to note that. So the priority then, for us, at least in the evidence space, is to look at what is the effect of the strategy, the mHealth strategy, on the intervention quality and coverage. For the majority of mHealth interventions for MICs, that's the relevant question. I threw these slides in about 3 minutes ago when a lot of the discussion was talking about pilots and ensuring the replicability of efforts. I think we need to recognize that mHealth as an innovative space goes through a series of stages of maturity. And pilots are relevant at the early stages in order to assess the feasibility, or sorry, the actual, the relevance of a strategy on a particular problem. And these stages are important for the kinds of questions that come up as researchers. So early on in the prototype phases, we're asking about the feasibility and the usability of the technology or the mHealth strategy itself. The efficacy is really about the effect of itself on the outcomes of interest. Effectiveness is in real-world settings, and the implementation science is the replicability and the institutionalization potential. So different questions, and we need to see that pilots are relevant at early stages there, and we shouldn't throw away pilots. They're a relevant part of that innovation phase. So again, those series of buckets of questions are relevant. Can they use the app? Do health workers actually use it? are there any health system improvements, and are there outcomes of interest that might relate to health outcomes? So similar questions. I think we just need to keep those in mind as we move along. So to come back to the MTurk, we looked at, we recognized that a lot of the articles in this space either describe the intervention very well and did not do the research very well, or they described the research very well, but you didn't know what the mHealth was. So, which is a challenge, because you need both if we're talking about this space and being able to make a recommendation about something. So we began to develop grading tools that took into account those two questions. So, there were two domains of interest: the quality of the methodological rigor, and those are really related to grade and others, and the quality of the information that come out of that. And you can see that we followed that same kind of principle and looked at an area in stockouts. And we looked at the grade for each of those different domains. And as you can see, at least in this particular area on stockouts, one would expect and hope the kind of quality of information indicators that you would see for a reported study would be 100% in both of these different domains. And in this case, some report only on the intervention, and you know what the mHealth is, but you don't know the effect, and vice versa. So there's a real absence of quality information out there in the space, at least related to this domain and others that I'm not going to go into now. And we have tables that reflect that. Overall, there is a lot of activity out there in different domains. There is an insufficient level of quality of reporting on what the mHealth intervention is and the quality of the research itself, and those two. So mHealth is both about those specific strategies, which I would say are verticals. Does this thing affect an outcome of interest? But it's also about a lot of the integrated solutions that we're seeing are critical for governments to want to adopt. So we looked at, we borrowed from the Tanahashi framework. A lot of you may be aware of the 1978 article by Tanahashi that looked at health systems strengthening and the barriers to coverage. And we broke those down and looked at mHealth as it related to each of those different strategies, as it related to each of those different layers of the UHC. We borrowed this to reflect on universal coverage of health. But we reflected on the fact that there are mHealth strategies that are relevant at each of these stages. And in each of those stages, one should be able to measure the effect that an mHealth strategy has on each of those layers related to an intervention. So there are definitions, and all of you can, I'm happy to share that with you. The last 1 minute is really about the fact that when you look at all those layers and you're looking at an outcome like facility-based delivery, those cascading layers are all important. There's a strategy that's relevant to ensure that a client gets to the facility, that they get the right treatment, the right time, that that's fulfilled, and that they are not being burdened by the financial costs of transportation. So aiming at all of those different tools, all those different constraints in a coherent way is really about, I think, this future phase of mHealth interventions as integrated solutions that tackle challenges that we face, like ensuring facility-based delivery, and that all of these different challenges like transportation, awareness, referral pathways all play into that outcome. And we need to tackle those in an integrated way. And that's the focus of MTurk for this coming year, is to look at 5 or less domains like facility-based delivery and ensure that we come up with an essential package for governments that are focused on achieving UHC in the post-2015 era to be able to use mHealth to strengthen that delivery of those interventions that they know work. So, thank you very much.
Thank you so much, Dr. Mehl. I mean, you've stuck to time, firstly, and also really compressed everything you've been doing in so many years into 15 minutes. So I'm sure there are going to be lots and lots of questions, but just to start with, just listening to you now, it reminds me of when we started in evidence-based medicine 15, 20 years ago. So you're talking about the need for evidence, and when we're 20 years ago, when we even talked about evidence-based medicine, we were talking about consensus methodology, not having any evidence, how we're going to develop guidelines, recommendations. And here we also have a dearth of evidence. And everything that you're doing, I suppose, is trying to drive up that quality. And when we developed guidelines, we brought together research fellows and clinicians. And previous to that, clinicians were trying to write guidelines themselves. And what comes across to me here is that, are we yet in that partnership, collaborative mode where we work with technologists and health professionals and bringing us together to actually produce the best research, rather than health professionals struggling to do it on their own and people in the technology world struggling to do it on their own? I just wondered if you could sort of reflect on that for a second.
Sure.
While everybody's thinking of their questions.
Yeah, I think that's a really important point, that those who are doing innovations, who are out in the field, who are experts in their own domains, are really good at understanding the functionality, the usability, ensuring that probably the technology meets the problem area that's trying to be addressed. But they're not often those who are experts in the domain of research and evidence generation. And I think that really provides an opportunity for groups like UCL and others in the academic sphere, as well as local researchers, to be part of that process at different phases. So whether that's the ideation phase and looking at formative research, or whether that's the phases of validation, that's the efficacy phases, or the implementation science and ensuring. I think there are different kinds of researchers that are relevant at different phases. And I think the challenge has been, I think, that individuals have tried to do all of those themselves. And it's been a huge hurdle and burden for a lot of people. And I think that naturally, those of us who've gravitated to mHealth, I think, have been sort of at that marriage of innovation, research, and I think really there's a real need to make sure that we bring in the best of these experts from each of these different kinds of domains, and as you say, sort of bring them together in council, both at the country level for generating evidence, and I think also at the synthesis level to ensure, for example, guidance documents are relevant for those who are implementing. So I think there are two sets of needs there, and I think you're completely right. I think there's a lot to be learned from those phases, earlier phases of evidence-based medicine, and the methods that were developed for that as well.
That's great, thank you. If you could put your hand up if you have any questions, and we have some roving mics. If you could introduce yourself, say where you're from, and then give us a question, please. There's one over here in the centre.
Hi, I'm Isaac Holman with Medic Mobile. Thank you for the presentation. The focus on both the content of particular mHealth strategies and then also the methods by which we evaluate them is really helpful. Kind of related to that, in the field of strategic management research, one of the biggest trends of the last 30 years has been a transition from focusing only on the content of particular strategies to also studying the methods by which leaders craft their strategies and bring them to bear in particular contexts. And this is, it's relevant in the field of mHealth. I think a lot of people will say it's hard to study things that change really fast and that are changing while a trial is going on. So my question related to that has to do with the graph you showed towards the beginning of your slide, where the evidence base for mHealth kind of started in the year 2000, and then there was an exponential curve, and most of it has been generated in the last 2 years. And I'm wondering how we decide, what evidence is useful to mHealth. I'm currently teaching with Claudia at the University of Edinburgh a 10-week master's course on mHealth, and we're trying to contextualize the evidence in terms of these longer, deeper traditions of research and strategy and management and development studies, but it's challenging. And so I'm curious, from the perspective of WHO, how do you look at different types of evidence from other fields, is there anything that, like if you have a paper that doesn't actually use the word mHealth in it, is it categorically excluded, or are there ways of thinking about how to incorporate that evidence or those learnings into our understanding of this emerging field? Thank you.
Thank you very much. Very interesting question about what is evidence, what sort of evidence do you use? Do you exclude evidence if it doesn't have that word in it, and how do you bring it all together?
Yeah, Isaac, thanks. That's a great question. I think there are a couple of ways of thinking about this. One is that there are critical keywords that would be important for any search strategy that would look to find evidence, and that should not exclude different not just the published literature, but also great literature and other things. So those keywords, search terms, are standard ways of doing that, I think. But I think your larger question is one that relates to how do you look at mHealth evidence differently than you would say when we're evaluating a guideline around a vaccination or something. And I think to come back to the earlier discussion that was taking place, we're very much looking at this as a health system strengthening approach, and therefore those outcomes that relate to processes, especially those coverage or quality measures, are going to differ by the type of, for example, stockouts are going to have different indicators of relevance than if you're using mobile technology for civil registration vital statistics. They both have their own domains of really relevant outcome areas, so we want to ensure that we're looking at those and that our evidence synthesis relates to those kinds of indicators, and that they're graded accordingly. So the emphasis there then is on ensuring that the process indicators are the relevant ones. Again, that framework, that modified Tanahashi framework, then becomes relevant to look at which levels of that coverage cascading model are you covering by the mHealth strategy that you're looking at, or the outcome of interest, and which strategies are relevant for those different domains. So to just simplify, I think you need to ensure that the process indicators are the relevant ones, and that the evidence synthesis should really focus on those, and that there is going to be an opportunity to have more health outcome data in some of the areas, but not all of them.
Thank you.
Yeah.
Any more questions? There's one up on the left-hand side.
Hi, my name is Seb Robertson. I'm an A&E doctor working. Sorry, I've lost my voice. A&E doctor working in Kent. Thank you for your presentation. Very enlightening to see all the different layers.
So it's hard to hear.
Sorry, I'll speak clearly. Seeing all the different layers as a clinician is quite mind-boggling, actually. So thank you very much for sort of articulating those. I was interested in your sort of thoughts on the role of private companies in delivering innovation, and in particular the role of the WHO in making some sort of policy statements regarding API environments for companies. One of the accesses for information, I think, will be through applications in the future. And is there any guidance on sort of on the way that information is locked down from companies or that kind of thing? Is that something that the WHO considers?
Thank you. I think that's an extremely important question, because we are struggling with this partnership with industry and how, like we did with the drug industry, how we actually navigate it.
Sure. So there are a couple of principles that are out there that you should, that we can point you to. One is the ICT4D principles, which all of the UN agencies and many of the donors have signed on to, which are principles of reusability, open access, open source, and I believe privacy issues are mentioned in there as well, but they may not be, they may not go into that in much depth. I think the issues of data privacy are ones that come up in resolutions that WHO has passed in 2013, and I think come up in some of the standards of the ITU, in some of the working groups that they're convening. In general, you need to ensure that the countries you're working in, you're following the national standards related to data privacy. Unfortunately, not a lot of countries have a lot of guidance in this area yet. So in that case, there is if you can't find those documents, and one of those places you can look is called HINGEX. There's a good synthesis of a lot of national strategies and national policies there. But you can also refer to the eHealth toolkit that the WHO has put out with the ITU, and it refers to different standards that are out there. And I think this is definitely an area that's beyond my expertise. So, but there are some documents out there, and I think the issue of private companies is, I think, not different from other types of organizations that you partner with, but you need to try to ensure that that the issues of data privacy, of where the data is stored, should be in the country itself, except the cloud has become challenging for that question itself. But the issues of privacy and encryption and also would hold true in any country that you work in. So I don't think WHO will make a policy statement around, in general, around the use of private companies to partner with. I think more it's the principles that the organizations in the UN and donor agencies, as well as implementing agencies as well, have signed on to. And the ICD4D principles are good ones to reflect on. So, and those should be things that you should be able to go to and talk to private companies about. I would encourage those of you who are developing in this space to look to see what content has already been developed by software programmers in this area and try to rebuild or reuse and build on top of what others have done, if at all possible. The principles of leave it behind. If you're working in a country, a country should be able to have the capacity to evolve the software themselves and modify it. And I was very encouraged by the Minister of Health in Ethiopia saying that they have a whole cadre of technicians who are looking at information systems. So that, a partnership with the ministry, for example, on ensuring that the technology that's being developed by yourself or by others is appropriate to those cadres and to the settings themselves will also be important. So.
Thank you. I think coming through quite strong is partnerships, expertise, identifying the right people who know, and then we bring our expertise, but ensure you have the right people around you to do this properly. We have time for probably a couple more questions. I think there's one at the back, yes, on the left-hand side.
Hi, Oliver from AMREF Health Africa. I was just wondering what your perception on was some of the role of sort of online information hubs could play in the standardization and synthesization of evidence. Just for example, I know that there's one called, I think, the mHealth Alliance, and whether, for example, the field of mHealth could learn anything from the International Aid Transparency Initiative in the way they've tried to synthesize some of their data.
Thank you. Sure, thank you.
Sorry, I don't need a microphone, I have one. Thanks very much for that question. Yeah, I believe that the information hubs are really important, and there are a number of them out there. The mHealth Alliance has transitioned their hub, the Health Unbound, over to HINGEX. So that's one place to look. And the other is mhealthevidence.org that USAID has largely contributed to. The work that GSMA has done on their IMD tracker. Kim? MDI, thank you. MDI tracker is a very good online repository of mHealth projects, where they are and who's supporting them. Also just a plug for registry.org, which is using the same classification taxonomy that the mTurg has developed, and having projects actually fill out that categorization so that they're cataloged in a consistent way. Is something that we've been working on with, it is live with UNICEF and Johns Hopkins and a few others. And that's also in USAID. There's also that. Again, that's a nascent site, but it does exist, and hopefully you should be able to find out what's going on, where there's evidence of which strategies work in the coming years. And I think that's really a good opportunity for collaborations to take place, both between the academics and those who are doing implementations.
Thank you. We've got time for one. There was one question in the centre, and that'll be our last question before we move on.
Liz Hoffman from Biomed Central. I was wondering, you're talking about implementation science as being the final step. How much implementation science is actually happening, and what sort of quality is it? Because I know there's somewhat of an issue with the quality of some of things that people call implementation science, which isn't genuine implementation science.
It's a very interesting question, because I heard the term about 3 years ago, and it was a real question: what is implementation science? Are people packaging it as the name implementation science because we don't know where that work should be packaged? Is there a definite definition, or what does it mean to you, really?
Yeah, so I'm not sure I'm going to define it here in front of the audience, but it's very much the question of, you have a known intervention and you're trying to get it scaled, you're trying to get it to the greatest proportion of the population that needs it, and the challenges inherent in replicating, institutionalizing, and ensuring that that intervention is properly scaled and implemented. Now, the quality implementation, you can have 100% coverage, but if no one's using it, and they're not using it effectively, then it's not having an effect. So it's those questions of not only coverage, but quality, and a lot of those questions of integration with and partnerships with government then become very relevant, because you're trying to make these kinds of approaches then the norm. So they should be thought of as by default in general practice. So it takes it beyond the does it work in multiple settings to how do we ensure that the integrity of the intervention is maintained, and that the widest proportion of the population that should be receiving the intervention does so, and in sustainable fashion. So that's a mouthful, but I think it really is that, it's that optimization phase that we don't often get very well, we don't do very well in after the pilots. So your question of who's doing it, I think, is a relevant one. I would say BBC Media has a really big challenge right now, if I could speak on their behalf, which I'm not trying to, but Nyanya is going to be scaled in 50 states in India. That, to me, is an implementation science question. And those questions of partnership with government, those questions of replicability and training, and how do you do that at massive scale, really come, and I would be fascinated to have that conversation.
Thank you very much. If you could all thank Dr. Mehl for taking the time out to speak to us this morning, and thank you very much.